Welcome to the Lima Children's Hospital, where children come first. We like to call it LCH. It's a specialist pediatric center, caring for all kids up till the age of 16. We are located right here in Wuse 2, Abuja. We have a remarkable sensitivity to children's needs, that is what stands us out. We are specialized in neonatology, with our state-of-the-art neonatal intensive care unit. We are also a general pediatric hospital.
Good afternoon everyone. Welcome to the Lima Hospital webinar for the month of April. We're starting off right now. I am Dr. Samuel Mogaji, a medical officer in the Lima Children's Hospital. And with me is my consultant.
Dr. Gabriel Wala, consultant pediatrician.
Thank you, sir. Welcome to the Lima Hospital webinar. You can see that the Lima Hospital is a multi-specialty hospital having 3 branches in the city of Abuja. One of our branches is located in the central area. That is our multi-specialty branch. We also have another branch at area 11, Garki, which is the cardiac care specialty branch. And the branch where we're speaking to you from now is the Lima Children's Hospital in Ademola Adetokunbo Crescent, Wuse 2, Abuja. So we're going to kickstart the presentations right about now. So very briefly, we'll be talking about the current trends in the management of pediatric bacterial meningitis, which I'm sure is a topic a lot of us are aware of, and this is just a reminder of the things that we know and the current practices that we should learn going forward. We'll be discussing with this outline, and I'll start off with a case of a child that was managed in the facility. We have a 5-week-old male who was referred from another hospital with complaints of generalized clonic seizures, body swelling, and altered consciousness. On examination, it was revealed that child was unconscious, pale, with bilateral pitting edema, pneumotonia, and heart rate as projected. Other findings were not contributory. So to manage this child, we admitted, ran an urgent PCV, full blood count, serum electrolytes, and creatinine, and the other investigations there listed. So the child was transfused with fresh whole blood under Laxis cover, managed with antibiotics and corticosteroids. Seizure chart was kept, and we also started with intravenous fluids and later moved to NG2 feeding. Other supportive care was also instituted. Child received IV antibiotics for 10 days and was discharged. We've seen this child on follow-up, and baby is doing very well. So, sir, how would we talk about these current trends, basically?
One would have expected that with the availability of a lot of gadgets, medical infrastructure, and broad-spectrum antimicrobials, as well as routine immunization programs that have incorporated some of the organisms that cause these infection, would have expected that there should have been a reduction in the surge of its prevalence. But contrary to that, we still see a lot of cases of acute bacterial meningitis with its attendant neurologic sequelae and deaths. So we came up with this presentation so as to understand some of the molecular events that happen that if we have a very good grasp of them, we'll be able to know how to limit some of the attendant complications and deaths that we are still witnessing. So there are some newer trends in the management of acute bacterial meningitis amongst children that can help limit some of these adverse outcomes.
All right, so to discuss the epidemiology, the actual incidence of bacterial meningitis worldwide is unknown, but we estimate that there is an incidence of about 1.2 million people, with a mortality rate of about 11% of these people. Unfortunately, most of these mortality cases consists of children under 5, and even worse off in neonates and young infants. But the risk of contracting bacterial meningitis is just in a range between 1 in 400 to 1 in 2,000 children.
Okay, one would want to know if the prevalence is the global incidence is largely unknown. How come such a such findings have been reported. Some of the reasons is that there are lots of places like in Africa where there is low level of reporting. If you have a look at this diagram, the schema that is uploaded, you find that Nigeria, for instance, has not been reporting cases of bacterial meningitis, or when people report, it's not actually a kind of comprehensive reportage. So a lot of work needs to be done. There are areas where there is no report at all. So this brings us to the need for us to actually heighten our clinical suspicion and also publish our findings so that there will be a holistic representation of the incidence of meningitis globally.
So it's also seen that in Africa, bacterial meningitis makes up about 1 to 6% of hospital admissions, and 8 to 40% of these hospital admissions are, all die, unfortunately. Pneumococcal meningitis has the highest mortality rates in children. Meningococcal meningitis, which is caused by Neisseria meningitidis, is the only form of bacterial meningitis that can occur in large epidemic outbreaks. And children greater than 4 years are mainly plagued with the pneumococcal meningitis.
Okay. Before the introduction of the pentavalent vaccines in our environment, H. influenza type B has been implicated as the most common cause of bacterial meningitis worldwide. However, it will be important to note that there are non-typeable H. influenza type B, and there are some serotypes which our vaccines don't cover. So we can still have pockets of infections from some of the serotypes that are not that the vaccines we have don't cover.
All right. At this point, I think I should announce that I saw a participant with a raised hand notification. If you have questions at any point during the presentation, please drop it in the chat or in the Q&A section, and we'll attend to it as the presentation goes on. Thank you very much. All right, so this just shows us the organisms that cause bacterial meningitis and the age distribution that is most affected. And we can see that in children that are between 0 to 2 months old, they are majorly affected by Escherichia coli, group B strep, and these organisms that have been listed here. It should also be noted that most of the time they come into contact with it because of the passage, maternal passage during delivery, and they are still in the point where they are dependent on the mother's immunity and haven't built up any immunity of their own. So they are very susceptible to these gram-negative. Also, in children 2 months to 5 years, they are affected more by Haemophilus influenza type B bacteria, strep pneumo, and Neisseria meningitidis. That is the causative organism of meningococcal meningitis. Whereas in children between 5 years to 18 years of age, Neisseria meningitidis, strep pneumo, and Haemophilus influenza is the major causative organism in this age group. So, sir, how would you describe the pathogenesis of bacterial meningitis?
Okay, the pathophysiology of bacterial meningitis, can take two routes. One is a hematogenous spread, where you have there's a prodrome of upper respiratory tract infection or GI infection. Some of these organisms resident in those areas can actually enter the bloodstream and are carried via the hematogenous route to the brain. These kids don't have the fight against some of these infections is actually functionally immature. So there is limited impedance to the spread of these germs from those points of entries to the CNS. And once they get to the CNS, there is actually proliferation because of the low levels of some of these immunologic agents in the CNS. They proliferate rapidly and cause some of the problems that we find in patients presenting with that. Now, another route of transmission is by direct invasion. Now, if there are infections like areas that are very close to the CNS, like if there's otitis media, mastoiditis, traumatic injuries following a road traffic accident with leak of CSF, the germs that have a route into the CNS can also directly invade the cerebrospinal fluid and cause meningitis. Then when they find themselves in the pathogens now, into the cerebrospinal fluid, because of the low levels of neutrophils and other things that would have phagocytized them, they proliferate rapidly. And when the body senses that something is actually going south, there will be, mobilization of immunologic macrophages and other cells that will further trigger some pro-inflammatory cascade, like production of interleukin-1, 6, tissue necrotic factor, that will cause damage in the CNS, destroying the cells, causing edema, and these are some of the things that bring about the clinical manifestations that we'll find.
All right. It's also worthy of note that the cytokines initiates an intense response. Some of this response is neutrophilic migration, local cell damage, and blood vessel thrombosis. Also, there's increased permeability of these blood vessels that can allow easy access and breakdown of the blood-brain barrier. The pathophysiologic implication of this in terms of how all of this translates into the signs and symptoms that we experience is majorly through three major ways in terms of the cerebral edema, vascular thrombosis, and the focal inflammatory processes that occur.
Okay, so the edema, the cerebral edema that results, will cause some symptoms that some of these patients present with, things like headache, vomiting. For those that the anterior fontanelle hasn't closed, those that are below 18 months, you find that the anterior fontanelle might be bulging. There's altered consciousness. Then terminally can have papilledema. Once with in older children, you can have hypertension with bradycardia, and the increased vascular permeability that follows some of these pro-inflammatory cascade, leads to the leakage of albumin. High molecular weight materials like albumin, when the blood-brain barrier is actually functionally intact, don't enter the CNS. But once there is increased vascular permeability, there is actually leakage of some of these high molecular weight proteins into the CNS, and which will help us in making this diagnosis when we get to the findings on CSF analysis. There's also reduced glucose in the CNS because of increased metabolic activities by the pro-inflammatory cells, as well as the pathogenic cells in the CNS.
All right. Because of the vascular inflammatory process, there could be ischemia and infarction, which will be responsible for most of the focal neurologic deficits that are noted. Some of these effects also result in focal or generalized seizures with worsening case of consciousness. In this index case that was presented, the child presented with generalized seizures and an altered state of consciousness. Also, inflammation around the cranial nerves, spinal nerves, and the nerve roots will be responsible for signs such as neck stiffness, Koenig's and Brzezinski signs in older children, usually from more than 18 months of age because of the delayed myelination. We can also have some cranial nerve pulses that might be presented.
If you had noted the previous slide, you find that there were specific cranial nerves that were listed. Or once you have abducent nerve affectation, abducent nerve runs the longest course in the CNS. So by the time you have abducent nerve palsy, is one of the things you find when there is marked cerebral edema, and one really needs to be very, very careful, because if you don't note that and go ahead with some of the specific investigations like lumbar puncture, the child might run into some problems. So the investigations that we do for patients that present with acute bacterial meningitis can be grouped into general or routine and specific. The general investigations include a complete blood count, blood culture, preferably if the child has been on some antibiotics, for instance. Bacterial culture might be indicated, so that it helps us isolate this organism. Up to 80 to 90% of the time, you can isolate the positive organism from bacterial blood culture compared to CSF analysis, which is one of the specific investigations. Other sepsis screen has indicated if there's any septic spots, omphalitis, like in our index patient, the swab can actually be taken from those points, and the organism, positive organism, can also be picked up from there. Other imaging studies, there are localizing signs, lateralizing sign. You might want to do a cranial CT or other imaging modalities as indicated. The specific investigation that is done for children coming presenting with acute bacterial features suggestive of acute bacterial meningitis is CSF analysis. It's not just enough to request for this CSF analysis. There are specific things you want to, request for. You want to know what the opening pressure is. You want to, know what the macroscopic feature of the CSF of the fluid is. If it's turbid, you already know that most likely you might be dealing with bacterial meningitis. The cell count is important, CSF protein, glucose, and gram stain.
Okay, so this is just showing us details that are needed in the investigation of, or in the analysis of the cerebrospinal fluid once it's taken through lumbar puncture. And this image here describes the process.
Okay, let's just remind us a bit, about what these are. The two pictures that can be taken. For a bit older children that can actually sit, and their trunk flexed as shown, then this has to be an aseptic procedure. You can see that the person performing this procedure here is well gloved, gowned, and stricter sepsis needs to be observed. For younger infants like our index, it's best they lie, by the side like this while an assistant flexes the child as shown. Now, you need to palpate the iliac crest on both sides and now come towards the midline. The intervertebral space that an imaginary line from the iliac crest leads to is L4, L5. So you can go a bit, cephalad. The space just above that L4, L5 interspace is the L3, L4, which is where the CSF can be collected. Now, as a further reminder, we know that the spinal cord is overlaid by the pia, arachnoid, and dura from inside outwards. So as you stick in the needle, you have to face it a bit cephalad, as shown here. Then once you pass through this, just before you enter the subarachnoid space, you feel a give. This cartilage here will actually form some form of resistance. So once you go through this little obstruction, you feel a give, and you can actually collect the sample.
Okay, so I see some questions on our chats. All right. Okay. Oh, okay. Low volume of sound. All right. We apologize about that. We'll try to improve on that. Again, please, let's be reminded that if we have questions, we should put them in the chat box or in the Q&A section. Thank you so much. All right, sir. So what are the clinical features that are seen in cases of acute bacterial meningitis?
Okay, in acute bacterial meningitis, there are two predominant patterns of presentation. One is the one that is more dramatic, but most children will not present that way. Then there is the other pattern that is less dramatic, like the first one. It's more of a prodromal feature, like upper respiratory tract infection or GI symptom. Then later on, the child becomes lethargic and irritable. This might take some days before they present to the hospital. But there is this more dramatic presentation that, although not very common, once a child presents in such a manner and something is not done urgently, they might die within 24 hours. So it's good that we know these two patterns and now try to heighten our clinical suspicion, so that once you see a child that presents with triad of fever, nuchal rigidity for older children, those that are above 2 years, and altered consciousness, like our index presented with fever, seizures, and loss of consciousness. You can see two of the components of this triad is already there. So if our clinical suspicion wasn't heightened, we wouldn't have been able to start treatment as we did and have a good outcome as we did.
All right. Okay, sir. So in terms of the clinical signs that are elicited, we have signs of meningeal irritation, which is neck stiffness and back pain, the Kernig's and Brudzinski signs, which are elicited in older children. Most of the time, we can also show that there are complications, and we can assess these complications. There are things that are measurable that we can check for. So these complications might be signs of raised intracranial pressure, which are sometimes headaches and vomiting, the bulging fontanelle in children whose anterior fontanelle is not yet closed, sutural diastasis also in younger children, unequal pupils, the Cushing's reflex, which is hypertension with bradycardia, and apnea. We have abnormal posturing also in some children, cranial nerve 6 affectation, papilledema, coma, and syndrome of inappropriate ADH secretion. All these feature as complications to acute bacterial meningitis. And every child that we manage need not reach this stage if we have early diagnosis, prompt institution of treatment, and management of this condition. So how do we make a diagnosis of acute bacterial meningitis?
Okay, as I mentioned earlier, we need to have a very high index of suspicion. Once you see a child that presents with a triad of fever, neck stiffness, and altered consciousness, think of meningitis. Then you should also go ahead to examine, do proper examination, check for neck stiffness for those that are above 2 years, and other signs of meningeal irritation like Koenig and Brudzinski signs. There is also the Lassing sign. These are signs of meningeal irritation. Once those signs are there, most likely you might be dealing with a case of meningitis. Now, having obtained some of these findings on clinical examination, should go ahead to do CSF analysis. It's something, it's a very important diagnostic test that needs to be done to confirm the presence or otherwise of bacterial meningitis. Now, the opening pressure of the CSF is very important. Usually, it shouldn't be more than 18 to 20 cm of water. But by the time you have levels that are up to 10 times that value, 100 to 200, and you know that most likely might be a case of meningitis. Now, if there is increased cell counts, what we also know as pleocytosis is also suggestive. If there is elevated CSF protein, earlier on I mentioned that because of the increased permeability of the blood-brain barrier, some of the high molecular weight proteins like albumin that shouldn't be in the CSF actually enters into the CSF, and that gives you very high levels of protein. So that's another important feature, a diagnostic feature of um, bacterial meningitis. There is also reduced CSF glucose. The reason why the CSF glucose is reduced is because of the increased metabolic activity there in the CSF. So once you check the CSF glucose and is less than 50% of the random blood glucose, that means as you're collecting the sample, you should also do the random blood sugar check of the child and compare. Once the CSF glucose is less than 50% of the random blood sugar check, it's as well suggestive. Now, gram stain is another test that can be done, although it has a very low sensitivity of around 60%, 60 to 90%, but is very, very specific. It's 100% specific. Once you do a gram stain and find a gram negative diplococci, for instance, you know that you're dealing with Neisseria meningitis. If you get a gram negative coco bacilli, for instance, you know it's H influenza type B, and by the time you find the gram positive cocci in chains, then you know it's streptococci. So gram stain is very, very important, and CSF culture as well. 10 to 30% of the time, you might be lucky to isolate the positive organism. Now, where there are facilities for PCR, you can actually do specific PCR for these common organisms that cause meningitis, and the yield with PCR is higher than that of culture and gram stain. So this is one area of promise that can be incorporated in our practice.
Okay, so this is to discuss the treatment modalities. It's important to immediately start antimicrobial treatments, even without lumbar puncture being done sometimes, when we are able to elicit signs of raised intracranial pressure, or that we are suspecting space-occupying lesions in a patient presenting with some symptoms making us suspect bacterial meningitis. Also, we should institute prompt antimicrobial treatment after lumbar puncture in those with seemingly normal intracranial pressure. The cranial CT is also important to rule out whenever we see signs to suggest space-occupying lesions. It's important that we get a cranial CT done. This can sometimes make us see a brain abscess, an epidural abscess, just so that we are sure of the signs that we've elicited.
And another important reason why you need to be very careful that the intracranial pressure is not raised is that if you do a lumbar puncture, the child might actually cone, and the child you're trying to help, sort out the ongoing infection, you end up causing some, serious problems. Some might even die in the process. So it's important that, any sign of raised intracranial pressure is ruled out before you do a lumbar puncture. And in the case of maybe there is suspicion of raised intracranial pressure, evidenced by some of the clinical features we've mentioned earlier, there are some precautions you can take. Precautions like You can give cerebral decongestants like mannitol, 10% mannitol at 1 gram per kg over 30 minutes. You can as well give steroids like Dexa before the procedure is undergone. Then another thing is to use a narrower bore needle. Instead of using a wider bore needle for the procedure, you can actually use something that is a bit smaller, so that when the CSF comes out, it doesn't rush out and cause lingulation or coning of the brainstem in the child.
So in the management of children with acute bacterial meningitis, there are times when in instituting supportive care, these children might need to be managed in the intensive care unit. Sometimes they even need to be placed on mechanical ventilation and all that, all facilities which are available in some of our branches. Here also, we carry out mechanical ventilation. So for the contraindications to having a lumbar puncture being done, as Dr. Nwala has mentioned, signs of raised intracranial pressure due to a space-occupying lesion is an absolute contraindication. Whenever we notice a midline shift or trauma to the vertebrae, these are indications to treat without having CSF analysis done. Infection at the site of puncture is also an absolute contraindication because of the fear of introducing other pathogens into the CSF. And if you remember, because of the low immunogenic state of the CSF, we will be doing more harm than good in such children. Relative contraindications are raised ICP without space-occupying lesions, which in some cases we can give the medications as have been mentioned earlier. Coagulopathy and brain abscess are also relative contraindications. Now to the main part of this presentation, which is the current trends, because I'm sure that a lot of us are aware of most of these other things and they just serve as reminders. So what is the current trend? Where is this management leading to in the 21st century?
Okay, that's currently, we've transited from the era of having children with acute bacterial meningitis leaving the hospital with a lot of neurologic sequelae, not being able to talk, not being able to see, having hearing deficit, or having some motor deficits. There are things that can be done, as we do in our facility here, that can limit such mobilities. In number of patients we've managed there, we've not had any that had such sequelae. The preventive measures that are ongoing, like the routine immunizations, pentavalent vaccine that is currently part of the routine immunization has H influenza type B as part of it. Now, this H influenza type B is being reported that with the introduction of H influenza type B in developed world, infection, by this pathogen H influenza type B has been reduced to by up to 94%, just to tell you the importance of this vaccination. So it's some of the things that we are already doing should be encouraged, like routine immunization. Now, the introduction of PCV vaccines as well in our routine immunization programs, has also been a way of reducing or limiting some of the problems that come with this infection, acute bacterial meningitis. In areas where there are epidemics, like the meningitic belt, cerebrospinal meningitis vaccines, are also given in those areas, and this has actually helped. But it will be important to state at this point that in as much as these vaccines are available and are being given, there are different types of vaccine, like the H influenza type in one of the previous slides we shared. you could see the different serotypes. Some of the vaccines we have don't have all those serotypes covered. So you might have a child that has been vaccinated against H. influenza type B, for instance, still presenting with acute bacterial meningitis. In as much as it will reduce the incidence or the prevalence, there's also that risk that those that were vaccinated against some certain serotypes might be infected by the other ones. Now, there are also non-typeable H. influenza type B, which can cause more serious infection, though it's not very common, but just know that those that were vaccinated routinely might still be infected by that. The same thing applies to strep pneumonia vaccines. There are vaccines that are that have 7 serotypes. There are some that have 10. There are some that have 13. There's also one that has 23. So that a child got, PCV, for instance, below 2 years. There's also a vaccine that can be given above 2 years, because the protection that these ones that are given below 2 years don't really extend to beyond that period. Prophylactic antibiotics for those at risk, like if there's somebody that is being managed for acute bacterial meningitis, for instance, household contacts, especially if there's infection by H. influenza type B or Neisseria meningitis, there are very high chances that household contacts might be at risk of getting this infection. So prophylactic antibiotics, using rifampicin and Cipro can actually help protect these household members. Now, I mentioned earlier that PCR, can actually help you isolate some of the antigens, that are specific for some of these 3 common pathogens. So if one has this investigation modality available, it will help you make a clinical decision regarding what is causing this meningitis and how long do I need to treat for the child to get well. I had mentioned that CSF culture has a very low yield of 10 to 30%.
Yeah.
So when you have PCR available, it's one of the new things that is currently done. Now, corticosteroids, helps prevent neurologic sequelae. In the pathophysiology, we try to explain what happens, the pro-inflammatory cascade, the interleukins, and the tissue necrotic factor that will damage some of the cells in the CSF that will cause these neurologic sequelae. So if corticosteroids like IV dexamethasone is given before or with the first dose of antimicrobial, it stabilizes the blood-brain barrier and limits some of these pro-inflammatory cascade that will cause the sequelae. And this we've been doing in our facility. And small wonder then why we don't have such sequelae in all the children we've managed there. Now there is this other treatment modality that is currently being advocated, glycerol. There are some cough syrup that contain this glycerol. It increases plasma osmolarity, reduces CNS edema, and enhances cerebral circulation. There are some brands of cough syrup that you can look for this glycerol. There's one we have that we use here, and it's been helping us have very good outcome.
All right, so we have a question in the Q&A box by Dr. Christian. Thank you. So he asks that, please, what are the measures on admissions that can be instituted to prevent sequelae like hearing and visual loss? And is there a place for mannitol in the management of raised intracranial pressure associated with meningitis?
Okay, this question actually came before I talked about the role of corticosteroids.
Yeah.
Now, corticosteroids, even in the literature has been shown to limit some of these neurologic sequelae. Now, those that did some randomized control trials, with patients that received corticosteroids and those that did not get, there was actually a very significant difference between those that got corticosteroid in terms of not having neurologic sequelae compared to those that didn't get. So use of corticosteroids, actually helps to prevent hearing loss, visual impairment, motor, and other cognitive sequelae that can follow. Now, the use of mannitol is actually controversial. Now, if there are obvious signs of raised intracranial pressure, one of the precautions you take is to give mannitol so that the edema, comes down a bit before you collect the CSF sample for confirmatory test. So we use it on some occasions when indicated, like if the child has had repeated seizures, the more the child has repeated seizures, the likely that there might be cerebral edema. And those that have overt signs of raised ICP, will give them 3 doses of mannitol, 1 gram per kg, to run over 30 minutes, 8 hourly, and 3 doses. Once we offered them that treatment modality, it helped us also salvage them.
Okay.
So these are the other rapid diagnostic tests. Now, the good thing about some of these tests is that it can be done within minutes or hours. So instead of waiting for culture, that might take some, in our facility, our cultures take like 2 to 3 days, sometimes 5 days, depending on whether there is yield in the preliminary culture. So these tests like counter current immunoelectrophoresis, lattice agglutination, ELISA can help isolate some of these pathogens faster than with the culture. Then there are some slight limitations for each of them. For instance, a ELISA test that's enzyme linked immunosorbent assay can actually be used for a large number of samples when compared to lattice agglutination and countercurrent immunoelectrophoresis. Those ones, you can only handle a sample at a time. So when you have so many samples to handle within a short time, ELISA might be promising. Now, CSF lactate level, though is raised in acute bacterial meningitis, is not specific for acute bacterial meningitis. If there is ischemia, malignancy, encephalitis, and even in a seizure disorder, for instance, you can still have raised CSF lactate level. So it will be good to, do some of those tests that are more specific for acute bacterial meningitis when compared to these other ones. Now, isolation of the enzyme activity, this beta lactamase enzyme in the CSF is also another important test that will help one know that strep is responsible for the meningitis, for instance. Now, if there are skin lesions like petechiae or pupillary lesions, gram stain of those lesions can also help you identify some of those organisms.
All right, thank you, sir. So we have a couple of other questions. An anonymous attendee asks, what type of cerebral edema is found in pediatric meningitis? So in pediatric, when we discuss the pathophysiology, we discussed that sometimes we have local tissue damage, especially because of the arcade of inflammatory responses that happen whenever the system is reacting to the presence of pathogens in the CSF, part of which is also worsened by antibiotic use, might I mention, because this will now break down a lot of these organisms and cause greater response. So sometimes we observe the cytotoxic edema, which is a major cause of cerebral edema in patients with pediatric meningitis. We have another question also that says, what age in children can we be on the lookout for tuberculous meningitis?
Okay, we are not actually discussing meningitis generally, because if we should talk about meningitis generally, this little time we are using may not be enough. We are limiting ourselves today to acute bacterial meningitis. So when we talk about TB meningitis, we'll be able to, throw more light on that.
Okay, so in discussing the prevention of bacterial meningitis, I'll discuss it in these 5 layers. In general health promotion, this level basically deals with awareness and educating people. We discussed that some of the way that the bacterial meningitis is spread to the CSF is through hematogenous spread, following some viral infections like upper respiratory tract infections or acute gastroenteritis. So basically, we just want to educate people about, proper hygiene and ways to avoid getting these easier, so to speak, illnesses before progressing to the greater bacterial meningitis.
So let me just add, general health promotion, things like environmental sanitation is very important, because if our environment is clean, some of these germs will not be able to grow and infect our children. Things like health education, as we are doing now, good eating, we are doing it amongst health workers, so that we'll be able to also pass down this information to our patients that present to us. Beyond just treating them, we should also help them know some of the things that they can do to prevent recurrence or infection of these infections to other of their children or even their neighbors. Now, for specific protection, immunization, routine immunization, mass immunization programs, then special optional immunization for people, for at-risk people like children with sickle cell disease, asplenia, nephrotic syndrome patients on chronic steroid that will reduce their immunity and predispose them to infections. Now, another thing that comes under specific protection is chemoprophylaxis. We've mentioned that those that have infections from H. influenza and Neisseria meningitis can actually get chemoprophylaxis like rifampicin or ciprofloxacin to protect them from also getting to manifest these features of meningitis. Now, we need to have a very high index of suspicion. Every fever is not malaria, typhoid malaria, and maybe a little hepatitis.
Typhoid with some
that's just
plasmodiasis.
so we should have a very high index of suspicion. Once you see a child that presents with the triad of fever, neck stiffness, and altered consciousness, think of meningitis. I've seen a child that just presented with neck stiffness. There was no fever. There was no other feature. The consciousness, the child was just fully conscious, but just neck stiffness. By the time we did the CSF analysis, it was confirmatory. So we should heighten our, clinical suspicion. Then treatment should be started early. Don't, once you've seen the features there, and maybe for one reason or the other, maybe you have poor laboratory support, you're not able to analyze the CSF and all that, you should start treating. the guide that we shared, different ages and different organisms, you can actually use it to know the likely organism. Like a child that is less than 2 months, for instance, most likely heterogenic organisms like E. coli, if there are infections maybe on the skin and all that, you think of the possibility of Staph aureus. If there's otitis media, you think of strep. Now, there's a code that can be used to know how long you can actually treat, so that you don't do partial treatment and the child still ends up with the sequelae you're trying to prevent. There's this NHIS code, N for Neisseria, H for Haemophilus influenza, and S for strep. So for Neisseria meningitidis, you treat for 5 to 7 days. For H influenza, you treat for 7 to 10 days. While for strep, you treat for 10 to 14 days. Now, for gram-negative organisms in neonates, you have to treat for as long as 21 days. If you isolate Listeria or E. coli, you know that you have to treat for 21 days. So, limitation of disability, if there are complications, can actually help by judicious use of IV fluid can actually help, and the choice of fluid you're using. A lot of people, in older children use pediatric saline, for instance, 4.3% of saline. Now is a hypotonic solution that will cause edema on its own. Now you're giving it to a child with meningitis. By the end of the day, the edema that you should even prevent from happening now happens. Those that have acute kidney injury from the sepsis can benefit from dialysis. Those that have respiratory difficulty can actually benefit from continuous positive airway pressure. Rehabilitation for those that maybe present late when these features are active. Then neuroprotection, another limitation of disability, neuroprotection by corticosteroids is another important thing that can also help reduce neurologic sequelae, which we are doing and is working for us. For rehabilitation, those that have already come down with speech impairments, hearing impairments, and motor deficit can benefit from speech therapy and physiotherapy as indicated.
Okay, Dr. Nwala also mentioned about treating the strep pneumo for longer duration than in cases of Neisseria or Haemophilus influenza. It's important to remember that strep pneumo causes the greatest mortality in under 5s, it alone responsible for 20 to 40%, whereas in cases of the Neisseria meningitidis or Haemophilus influenza caused meningitis is responsible for about 8 to 15% mortality. So for prognosis, appropriate antibiotic therapy, has been shown, and at the correct dose via the correct routes, has been shown to reduce mortality to less than 10% in most cases. And as I mentioned, greatest mortality is seen in cases of pneumococcal meningitis. And we have severe neurodevelopmental sequelae in 10 to 20% of the cases. Unfortunately, not all of the management that can be instituted can prevent this sequelae in some cases. And then we have neurobehavioral morbidity in about 50% of cases.
Okay, so those that present early, in most centers, when some of these patients present late, by the time they present to the hospital, they've already started having some of these sequelae. So for those few fraction, you can still have some of these neurodevelopmental problems. Not, meaning that those that come early should be kept and diagnosis delayed before you start instituting something.
All right.
So would want to conclude by saying that acute bacterial meningitis is still a leading cause of presentation of fever, altered consciousness, or convulsion in our emergency rooms across our different places of practice. So it's important that we heighten our clinical suspicion, make diagnosis of acute bacterial meningitis early enough, start antimicrobials and other supportive measures. If we do all these as we are doing here in Limi Children's Hospital, we'll be able to further limit the morbidity and mortality accompanying this clinical condition. Thank you.
So that brings us to the end of today's presentation, and we'll give some time for questions from some of our participants. If you have any questions, please drop in the chat box or the question and answer session. Let's quickly handle that.
Somebody's hand is raised.
Okay, thank you. Thank you, Dr. Sampson. Any questions in the question and answer box? Okay.
So means that
We've been very well understood.
It means two things.
Or we've not been understood at all.
That we've ended up confusing everybody, or everybody understood what we said. So we don't know which one it is. You can help us in the comment box for us to know what's actually, is the case here. Is it that the presentation was well understood, or that you didn't understand anything?
Okay, I think majority of the feedback is that it was well understood.
Okay.
Thank you, Dr. Uche Okpara. Thank you. Yes, you can have the slides. If you register, the slides will be sent to your email.
Okay, there are two additional messages.
Okay, thank you, Dr. Michael.
Okay, well
All
understood. Right. Thank you. Okay, are there questions from those
from
that
our
are
physical audience?
Physically present? Okay. Thank you.
All right. Thank you for joining our presentation. Again, this is the Limi Children's Hospital and one of the branches of the Limi Hospital groups in Abuja, Nigeria, West Africa. Thank you for joining us. So we hope to have you with us next time.